Thank you for having me. I'll give a presentation on atrial cardiomyopathy. Let me first present the case. I consulted from a GI. A 78-year-old woman was found to have a splenic infarction instantly on a CT scan. At the time, her ECG showed sinus rhythm, and Holter ECG showed subsequently performed, which detected atrial fibrillation, leading to the immediate initiation of anticoagulation therapy. This case is similar, but the process is different. A 76-year-old male patient was instantly found to have a splenic infarction on a CT scan. However, his ECG showed sinus rhythm, and no AFib was detected on the subsequent Holter monitoring. Atrial fibrillation is the most common sustained arrhythmia associated with high risk of stroke and thromboembolism. Evidence suggests that thrombogenesis in AFib is linked to several mechanisms. Traditionally, stroke in AFib were thought to result from a clot formation in LA appendage due to local stasis, which could embolize to the brain, especially after restoring sinus rhythm. However, current evidence challenges this linear sequence of AFib, blood stasis, thrombus formation, and embolization. New perspectives have emerged questioning the traditional chronology of this event. For male AFib patient with a CHA2DS score of 0, the risk of ischemic stroke was similar to the non-AFib patient. This suggests that in male patient, a score of 0 indicates minimal thrombogenesis even with a persistent AFib. In contrast, for female patient with CHA2DS score of 1, AFib remained important risk factor for ischemic stroke. This difference indicates that gender influences the risk of ischemic stroke differently AFib and non-AFib patients. The current approach to identifying individuals at elevated risk of stroke, the therefore candidates for oral anticoagulant therapy is based on the CHA2DS score rather than AFib alone. Cardiac amyloidosis is associated with an increase of risk of thromboembolism event, including stroke, even in the absence of AFib. This event can occur despite sinus rhythm and no evidence of AFib, and are linked to the severe atrial contractile abnormalities. Severe atrial and ventricular amyloid infiltration may lead to mechanical atrial standstill, resulting in thrombus formation. These findings suggest that patients with severe cardiac amyloidosis may require anticoagulation when atrial function is impaired. According to ASSERT study, only a small percentage of stroke were preceded by detected AFib events. They found AFib was detected within 30 days before stroke in only 8% individual, and 60% stroke victims have their first AFib even after stroke. Investigating on the impact study demonstrates similar lack of temporal relationship between AFib occurrence and stroke events. This lack of a clear temporal relationship suggests that additional factors beyond AFib may contribute to stroke occurrence. There is a growing evidence suggesting AFib may not be the primary cause of stroke, but rather an indicator of underlying atrial disease. This talk aims to introduce and explore concept of atrial cardiomyopathy regardless of presence of AFib and investigating relationship among atrial cardiomyopathy, atrial fibrillation, and stroke. Leading international societies convened a working committee to create expert consensus document that defined atrial cardiomyopathy. Atrial cardiomyopathy refers to adverse structural, electrical, and functional abnormalities of atria which can occur regardless of AFib. The extent of these atrial cardiomyopathy refers to adverse structural, electrical remodeling, but may contribute to development to the AFib. This extent of these pathologic change may vary over time and across different atrial locations. The Heart Rhythm Society have published the only available classification of atrial cardiomyopathy. It is important to note that this classification does not relate to the severity, temporal progression of this condition. Atrial structural remodeling and dysfunction often occur with atrial arrhythmia. Animal models showed that sustained rapid atrial pacing induced atrial fibrosis, while restoring sinus rhythm after AFib ablation reduced LA size. Increased LA size is linked to higher risk of AFib and its recurrence. LA fibrosis indicated by late guidewire enhancement is associated with reduced atrial conduction velocity. Increased fibrosis on CMR correlate with thrombus presence and spontaneous echo contrast. Reduced LA contractile function is related to the higher rates of paroxysmal AFib. And in echocardiography, LA reserve function and assessed by atrial strain image may reflect early fibrosis and help identifying patients with cryptogenic stroke. And cauliflower morphology and low LA emptying velocity and reduced contraction and prediction of ischemic stroke. Moreover, various studies suggest that fibrosis is associated with aging, hypertension, and diabetes and obesity. Besides the AFib, several ECG markers and continued monitoring data have been linked to the stroke event. Excessive premature atrial complex increase the risk of stroke and are associated with a higher incidence of AFib, adverse atrial remodeling, and impaired function, including increased LA volume and reduced LA contractile strain. Similar associations have been seen in PT-FEV1 and IACD, which also correlate with the increased LA volume and reduced phasic function. Some studies suggest there a link between PT-FEV1 and ischemic stroke. Inflammation and endothelial dysfunction contribute to platelet adhesion and coagulation and thrombus formation. Atrial stretch and myocardial injury release atrial natriuretic peptide and troponin, leading to fibrosis and increase the risk of stroke in AFib patient. Elevated natriuretic peptide linked to the electrophysical change are associated with stroke risk even after adjusting for AFib. Inflammation markers like CRP and interleukin-1 also correlate with ischemic stroke and recurrence. Endothelial dysfunction and hypercoagulability increase the stroke risk in both AFib and non-AFib patients, and elevated von Willebrand factor and D-dimer are linked to the stroke risk and LA size. Despite anticoagulation, inflammation persists and reinforces the role of endothelial dysfunction in stroke patients. This diagram is illustrated the stage of atrial myopathy with aging and inflammation in atrial stretch and oxidative stress. Atrial may develop myopathy at stage 1, which is not clinically detectable. Once fibrosis and atrial remodeling occur, atrial myopathy is detectable at stage B, but the individual remains asymptomatic. As inflammation and remodeling continue, AFib and stroke develop, leading to clinical attention. AFib-created prothrombotic state that exacerbate fibrosis and inflammation at stage C. Atrial myopathy can be reversed with intervention like lifestyle change and successful AFib ablation. Without intervention, the disease progresses to the stage D and the end stage of atrial cardiomyopathy. To summarize what I have presented so far, abnormal electrocardiography and echocardiography indices, along with biomarker and relative underlying inflammation, fibrosis, and endothelial dysfunction, confer an elevated risk of ischemic stroke in patients with AFib and without AFib. Next, I will introduce studies related to atrial cardiomyopathy and stroke. Unrecognized atrial cardiomyopathy may experience some cryptogenic stroke, as it can create a thrombus formation site even without AFib. Several factors such as LA size and PT-FEV1 and the NT-proBNP have been linked to the stroke independent of clinical apparent AFib. This supports the idea that atrial cardiomyopathy, not just AFib, causes stroke. The study aimed to assess how markers of atrial cardiomyopathy such PT-FEV1 and LA dimension and NT-proBNP and incident AFib were linked to the ischemic stroke. Results show significant association with stroke for PT-FEV1 and NT-proBNP and incident AFib, but not LA dimension. This suggests that thromboembolism from the LA can occur in the presence of various forms of atrial disease even without clinical apparent AFib. This study is aimed to determine if these markers improve stroke risk reduction beyond the traditional CHA2DS2-VASc score. Moderate to severe left array enlargement was defined array diameter greater 44 millimeter, 43 millimeter, and excessive atrial ectopy as greater 30 atrial premature beat per hour. In result, array was associated with a nearly two-fold increased risk of ischemic stroke, while EAA had no significant effect, adjusting for instant AFib. In conclusion, array enlargement was independently associated with increased risk of ischemic stroke in the absence of AFib, and both array and EAE improve stroke risk prediction. These findings have implications for stroke risk stratification, AFib screening, and stroke prevention before onset of AFib. This study investigated the hypothesis that atrial myopathy may be linked to the ischemic stroke in HFpEF patient. AFib and HFpEF are closely linked with progressive array remodeling, correlating increasing AFib burden in HFpEF patient. Given the strong association with HFpEF and cardiomyopathy, this study conducted post-hoc analysis TACE trial to explore role of atrial myopathy in stroke in HFpEF patient without known AFib. Atrial myopathy was defined array enlargement, elevated natriuretic peptide over medium 2 years, with atrial myopathy being associated with significant higher stroke risk, and diabetes also an independent predictor. These findings suggest that atrial myopathy increasing risk ischemic stroke in PEF patients without AFib warrant further research to guide stroke prevention. APCIS present the heterogeneous group of ischemic stroke, accounting 70% of cases. Studies comparing oral anticoagulant and aspirin for stroke prevention in APCIS, including Navigate APCIS and Respect APCIS trial, showed no significant benefit for oral anticoagulant. However, in the Respect APCIS trial, patients over 70-year-old showed significant benefit from low-dose dabigatran compared to aspirin. So while the broad use of oral anticoagulant for APCIS appeared ineffective, a cardiac trial was investigated. The ACARDIA trial aimed to test if anticoagulation is superior to antiplatelet therapy in preventing recurrent stroke in patients with recent ketogenic stroke in the evidence of atrial cardiomyopathy. Atrial cardiomyopathy was defined as elevated PT-FEV1 and T-proBNP and array enlargement. The primary efficacy was recurrent stroke. The trial included 10,000 patients and found no significant difference in the rate of recurrence between APCIS group and aspirin group. No significant evidence of the heterogeneous treatment effect on the primary efficacy outcome was found across the pre-specified subgroup group. APCIS did not appear to be greater benefit than aspirin at the higher level of atrial cardiomyopathy biomarker. Atrial myopathy can manifest as AFib, non-AFib arrhythmia, abnormal atrial size, and impaired atrial function. Detecting it, especially in those at risk of AFib and stroke, involve methods like non-AFib arrhythmia and atrial electrogram and imaging modality. These can identify atrial myopathy and assess stroke risk and array size linked to AFib recurrence and stroke risk, which challenge remains in routine use, but advanced imaging and some biomarker offers improve stroke risk stratification. Additionally, AFib ablation may lower risk of low stroke risk, suggesting post-ablation evaluation to determine anticoagulant therapy needs. However, to validate these hypotheses, to better understand their implication for clinical practice, there is a need for prospective RCT. In summary, although AFib increases stroke risk of 5-fold, the lack of temporal association between AFib and stroke event had led to the description of a new paradigm, where AFib would be considered a marker of atrial cardiomyopathy rather than a cause of stroke. Current risk stratification scheme and management strategy do not consider the underlying atrial cardiomyopathy and AFib. Further research will be necessary to determine optimal strategy for assessing atrial cardiomyopathy to permit efficacious targeting of anticoagulant therapy. Thank you.